Thanks for the introduction, Libby. And today I'm going to talk a little bit about the state of the art in terms of surgical care for pancreas cancer and some of the advances that have been made over the last decade. I'm going to try to talk really today about what surgeons use to make decisions, how we make decisions, and what we have to, what challenge that we meet. Really, what we're trying to do for all patients with pancreas cancer is to get to this, which is that the cancer is out of your body, and that and to try to cure patients. And that, as Libby said earlier, the role of surgery for pancreas cancer remains the best opportunity for treatment. It is really the only treatment that offers the potential for cure. In addition to removing the cancer, the goals of surgery include relieving symptoms, removing the cancer in its entirety, and hoping to improve long-term survivals. And I really want to say that it's important to combine surgery with chemotherapy. So neither surgery alone is the best, and chemotherapy by itself. Neither of these modalities or radiotherapy are by themselves the best treatment. The best treatment includes all of the modalities, of which surgery is the best treatment if possible in combination with chemotherapy. And you can actually see, and I've just presented some of our data for Princess Margaret and Mount Sinai combined. We really have, if you look at the red chart, if that over the last decade really improved the survival for patients who undergo surgery for pancreas cancer. And I think one of the important things to recognize is that pancreatectomy, which is surgical removal of part of the pancreas, has evolved over the last couple of decades. And this is because of a number of things. One of them is that patient selection is better. So we have better tests to allow us to determine whether surgery is going to be an effective treatment for patients. And that really includes better CT scans, the introduction of endoscopic ultrasound and MRI, and all of these modalities together allow us to select and better understand who may benefit from surgery. Perioperative care is also better, and that means not only preoperative assessment, but postoperative care and getting patients well enough so they can go on to the next step of treatment. And as part and parcel of that, that pancreas surgery has become safer. And over the last couple of decades in surgery, not just in pancreas or cancer surgery, but in all areas of surgery, we know that many complex procedures have a marked volume outcome relationship. And that really means that practice makes perfect. So surgeons and institutions with more experience into procedures have an associated lower perioperative mortality rate, and also this translates into not only short-term better outcomes, but also they have better long-term outcomes, and there's less cancer-related mortality either in the short-term and the long-term. So that these kinds of advances in surgery have made a difference, and you can see in the graph here that you can actually see that over time, that the number of patients who are able to undergo surgery increases. So even if you have more perioperative comorbidities, you can still have surgery, and the perioperative complication rate is lower. So surgery is safer. We're better able to select and identify patients who are likely to benefit from surgery. And these are actually big advances. Not only that, but surgeons have evolved, and I don't mean from apes. I mean that hepatopancreatic surgery, this complex cancer surgery for pancreas disease, we're now specialists. So all of us, and Steve is probably the first generation. Hopefully I would consider myself the second generation of surgeons who really subspecialize in this. So we do this all the time. This is what we do every day, day in and day out. And so that we're better surgeons because we do a lot more of this kind of surgery. We're also better oncologists, which means that we're not just surgeons, we're surgeons who specialize in cancer, so that we understand not just the operation, but the disease, what it means before, what it means after, and how these things impact on your short-term and long-term survival. So I think that as surgical oncologists, we're better at that. We are good. We collaborate with cancer centers, and we're lucky enough to be affiliated, I would say entrenched in a cancer center, Princess Margaret. So we have the opportunity to have amazing medical oncology colleagues, radiation oncology colleagues, but also nurses, anesthetists, a research team, everybody who also does this all the time. So that makes a big difference, and which means that we can do things that surgeons didn't do before, which is give chemotherapy before surgery, these neoadjuvant approaches. So all of these things add to what we're able to offer patients and add to the ability to offer more surgery to more patients in a safer way. We also have an advanced technical toolbox, which is just a fancy way of saying we can do all sorts of interesting stuff. Technical reconstruction that is not available at a lot of other centers, and that's because we practice it every day by doing it every day, so that we have a high volume experience, so that things that used to be prohibitive, like vascular resections, removing veins, removing arteries, are now routine. So when I trained, I don't think of myself as that old, but when I trained, portal vein resection was not routine. It was really something that we didn't do. If we saw patients with veins involved, we didn't think that surgery was going to benefit them because we didn't think we could do it safely. But now it's actually routine. 10% of our patients have routine, planned vein resections as part of their surgery. So that's a big advance over the last few years. And we do it by doing it safer. We minimize complication rates, so we get patients through surgery so they can get onto the chemotherapy, the adjuvant therapy, which really maximizes, the best long-term outcomes for patients. And so just as a sketch, so we haven't done this by ourselves. Cancer Care Ontario has been quite instrumental in this. In the 90s, they introduced standards for hepatopancreatic biliary surgery. That's what HPB surgery is in Ontario. And what they did was they regionalized care. They said, let's pick places where there's the right kind of surgeons, the right kind of ICU, the right kind of other services required to do this surgery safely. And you can see what they did is they restricted hepatobiliary surgery to specialist centers. There's 9 high-volume centers here who specialize in pancreas and also liver surgery, which is technically very similar, and of which you can see that in the GTA we have the highest experience in this area. And these are the kinds of things, the government has done to try to improve the quality of the care that we get. And the reason this is important is it allows us to do other things. It allows us to bring technical advances that allow bigger resections that we really weren't able to do safely before. So as I said, vascular resections, which is like planned removal of veins, are now routine. And arterial resections, which really have traditionally been the hard boundary between what we're able to do and what we're not able to do surgically. We're starting to understand that there may be an increased role for this and that we're doing it in a controlled way, trying to see whether or not doing pancreas resection where we plan to take out the arteries and plan to reconstruct them, we're gaining experience in this area. And this is something that requires not just cooperation and collaboration between the oncologist, the medical oncologist, and the surgeons, but it requires that surgeons have a special expertise where they're familiar with these types of vascular reconstructions. And on the flip side of that, not only can we do bigger operations, we can also do minimally invasive surgery, so that we can also do smaller operations. We can use laparoscopy in a staging. So laparoscopy means using small ports, putting telescopes in and doing surgery through what we call a minimally invasive approach, where we reduce the healing time to as low as it can be. So minimally invasive surgery, laparoscopic surgery we can use to help stage, to help us see whether or not patients might benefit from bigger surgery. And also I think that laparoscopic, bigger surgery with laparoscopic surgery and Whipple operations using the robot or laparoscopy are really the next forefront that we're about to address. And all of these things that are new advances over the last decade. The important thing about doing these complex operations is that we can do them to obtain negative margins, so we're able to extend the indications of surgery. So we're able to offer surgery to patients before who are not able to undergo surgery. And that's why these technical advantages as a whole are really important, because if we can get patients to surgery, we know that they'll do better and have better outcomes and have the opportunity for cure than if they're not able to have surgery. And this is obviously combined with the ability to get them through bigger, more complex surgery by making sure that they get the best post-operative care, that we mobilize them earlier and get them out of hospital as soon as possible so they can recover. So how do surgeons think, and how do we decide who surgery will benefit? Well, these are the key principles, and this is important for pancreas cancer and a lot of other kind of cancers you may know about or be familiar with, but localized disease, that means the cancer has to be only in the pancreas. If it's spread to other organs, then surgery is not the right treatment, because surgery is a local procedure that tackles the local area. It has to be technically resectable with R0 intent. That's really a technical term for saying that we have to be able to do an operation where we can get it all out. So taking 95% of it out or 90% of it out is not the right thing. So really have to try to design operations that can get it all out. And the patients have to be well enough to have this big surgery. And that's another thing that we have to assess before we think whether surgery is the right thing for these patients. And so these are the things that we want to do. We have negative margins, as I just said. We have to get enough lymph nodes so we know whether or not chemotherapy is going to be effective for them and adequately stage them. And we have to do it by trying to reduce the things that surgeons worry about after surgery. So the complications of pancreas surgery includes problems with the connections, healing, problems with the stomach working, and long-term things like diabetes and trying to reduce diabetes and some issues with when we remove the pancreas. So this is what we do. We assess resectability. We stage patients. We have specialized pancreas imaging that we now get on every patient. We use CT scans. We get MRIs. And this is what we ask ourselves: are metastases present? What's the relationship between the tumor and the major vessels? And on the side there, you can see that that's a CT scan at the top right-hand side for you that we're able to see very clearly. I wonder if I can show it to you. You guys see that? You can see the tumor. And, these images, the quality of them is very, very good compared to what it was when I trained. We took 45 minutes to do a CT scan. There were these little tiny pictures, and we really just couldn't see very much. Now we have a very clear view, and that really helps us decide whether or not that's really whether surgery is the right thing. And also you can see here, well, is this tumor, how close is it to this big white tube, which is a vein? Because those things, even if we know that that it's involved, we can plan for it before we know what we're getting into, and that really reduces complications. We can also get tissue diagnosis if we need to with endoscopic ultrasound. Now, if you're going to have chemotherapy or radiotherapy before surgery, that is really a mandatory component, and that's much easier to obtain now than it was in the past. So as I said, so just in terms of CT scans, we do thin CTs on everyone. MRIs are not routine for every patient still. PET scans we don't use routinely. And laparoscopy, which is putting a telescope in, it was very popular about 10 years ago. We don't do that routinely now. So this is what we think about in terms of deciding about what we should do in terms of surgery, what should be first, what should be second. Resectable pancreas cancer, which means patients who should have surgery first and chemotherapy after. That means we want to make sure they have no metastases. We want to make sure that their veins are not involved in any way based on imaging. And these are just some technical features in terms of it has to be not even close to the vessels. And for these patients, we recommend surgery first. It's a really classic approach. When we think about patients, when we think about the numbers that 10% of patients may benefit from surgery, this is sort of the traditional way that we think about it, is that if we can get it out and the veins aren't involved. What about patients who have a little bit more advanced disease? So the tumor is still inside the pancreas, but it's growing out a little bit, touching the blood vessels, maybe wrapping the blood vessels. So this idea of borderline resectable disease is when we think that there's probably a 50-50 chance that we get to surgery, that surgery might be possible, and that there's some common criteria that we use. And most of it has to do with the blood vessels that are involved, and I'll just show quickly that in a moment. But you can see that if we can design a way to get these patients to surgery, even if you have borderline disease, if we can do bigger surgery, take the veins out, plan to take the veins out, we know that the survival is better than if we're not able to do surgery. So this is a group that we're really interested in trying to tackle and offer surgery to, which before we were probably not able to do surgery for. And then this is just a quick picture in terms of what this is, and I really want you just to look at this, is that basically when we talk about borderline resectable, we mostly worry that blood vessels are involved. So that if blood vessels are involved, we didn't do surgery before, now we can do surgery now, but it takes a little bit more planning. So that's the borderline resectable. And then really, just for completeness, if there's spread elsewhere or there's significant vessel involvement, and those patients may not benefit as much from surgery still. So what about chemotherapy before surgery? And so this is another actually advance that has to do with the way we sequence treatment. Remember I talked about the borderline resectable patients, and those are patients 10 years ago we probably would not have been able to offer surgery for. But we think now what we can do is give the chemotherapy before to these patients and try to stabilize their disease and then do surgery. So this is another advance in strategy, and I'll just give you, this is a complicated slide, but just to let you know that there is research in the area. We recently finished a study. This is a study that's being published now, looking at neoadjuvant gemcitabine and oxaliplatin in addition to radiotherapy. And so these are patients, 2/3 of these patients are what we call borderline resectable, that a decade ago would not have been offered surgery. So what we try to do is we try to give them the chemotherapy and radiotherapy first, and then to see if whether or not it would help them get to surgery and get through surgery. And we could see that this type of neoadjuvant strategy, which is a new approach for this borderline resectable group, was was possible in patients, and that if they went through, and if they were able, and I'm not going to go through this whole slide, there was about 68 patients here. There was a multicenter trial that we at Princess Margaret participated in, but that basically, that if patients went to surgery, the chemotherapy was relatively well tolerated before, and if they went to surgery, we know that the green line are patients who had surgery, and the red line are patients who didn't have surgery. And it looks at, if you look at the difference, so that when things are higher, that's better. That if we were able, with this strategy, to get these patients to surgery, we know they did better than if they didn't have surgery at all. So neoadjuvant chemotherapy is one strategy what we use to try to offer surgery to more patients. And the next, this was something that we really didn't tackle even 5 years ago, maybe not even 3 years ago, is to really push the surgical envelope and talk about whether or not we can take arteries out. And the arteries and the veins that are near the pancreas feed the blood in and out of the small intestine, which is right next to the pancreas. And traditionally, we did not feel that we were able to safely remove the artery and that this would benefit patients. But we're really trying to look at that question now. And the reason we can do this is because we can do these bigger operations more safely in patients. And so we have a pilot experience with this at Princess Margaret Hospital. This is one of our surgeons, Dr. McGilvery, is championing this type of extended Whipple operation, and this is some preliminary data. We have about 13 patients who've had this operation. They're a little bit younger than the average patient, so they're in their mid-50s rather than their early 60s, which is the average patient population. We know that most of these patients, and you'll see at the top, right here, that 69% of patients had chemotherapy and radiotherapy before, as we talked about that neoadjuvant strategy to try to stabilize and perhaps shrink disease before surgery. And that if they were able to do that, that they were able to undergo surgery. All of them had their veins resected. 69% of patients, which is 9 out of the 13, had their arteries with a planned resection. So the safest way, so these aren't sort of, oh no, we have to do it now. These are planned resections, so we're able to do it in a controlled way. They were able to undergo surgery with a very good negative margin rate, which I think is on the next page, sorry. So you can see that in these patients, we're able to get the tumor out with very good negative margin rates, which really is the goal of surgery. And that although that the minor complication rate was, it's still a big operation in this patient, but the major complication rate is similar to a standard Whipple in a planned for these patients, and that their survival is similar to patients who are able to have surgery. So we know if we can develop surgical strategies in combination with chemotherapy and radiotherapy to get these patients to surgery, we know that their survival will be similar to patients who are able to have surgery at the beginning. So we know these types of strategies, so we can see this is the overall survival here, that we know that these patients do well from these big operations if we can get them to surgery. So really, I just want to conclude by saying that pancreas surgery, pancreatectomy, still remains the essential component of care for pancreas cancer in order to try to give patients an opportunity for cure. That resection, when surgeons think about it, what we're really thinking about is whether we can get the cancer out anatomically, and that we have to also think about the biology and the patient's fitness for these big operations, and that we're trying to extend the ability of surgery by offering surgery for patients with borderline resectable disease. And this requires a multimodality approach, working in conjunction with our medical oncology and radiation oncology colleagues, and that we can do a planned vascular reconstruction, which really is something that we were not able to do before, and represents a big advance in surgical treatment of pancreas disease. Thank you.